So, hello and welcome to another podcast by the School of Surgery. My name is Dr. Naomi Lasker and I'm one of the F1s at Royal Derby Hospital. I'm joined today with Dr. Rena Shornack, who is also one of the other F1s at Royal Derby, and Dr. David Restall. So we're soon to be F2s in about a week, but we thought that we'd pass on our wisdom and talk to you all today about how to be a good F1. So the objectives that we've got are keep an up-to-date job list, how to run an efficient ward round, prioritisation of tasks, how to know when to take breaks, raising concerns, handover of tasks, how to survive on calls, and any other odd tips that we can think of. So, we'll start with the importance of up-to-date job lists. Rena, what have you found over this past year?
Well, I think one of the most important things especially when you're starting a new job, is that your patient list is up to date and that you're familiar with it. So if you know your patients, you know who's on the list, you know what's on the list. If you get asked about any of your patients, you can always give a short summary about what's going on with them. And as part of that, you have on that list then all the jobs that you know need to be done for those patients. So you know where you're at with progressing through ordering an image to getting the result to taking it further. If you're working in a big team, I think it's really important as well that everyone is updating that list and adding to it so that you know exactly where you're at and that you can all work together and not cover the same tasks to make sure that stuff is getting done within the group and not getting repeated.
But David, what have you found over this year?
I think that the list is something that you're entrusted with wholly as an F1, whereas other things you can rely on others to help you out with. It's something that's really easy to get right, but if you get it wrong, you do look a bit of a fool. So especially when you're starting out, it's good to be organised. It's good to, like Rena said, have a list of all of your patients, past medical histories, outstanding issues, and just generic things that you're likely to be asked on a ward round.
I think I remember when we first came, we used to have to come in quite a bit earlier to start off with the list, didn't we?
Yeah, we did.
And keep things quite updated. But then I think as you go on, I think it starts off being about a good half an hour it take us just to update the list. But I think now we've got it down to about 5 minutes, haven't we?
Yeah, and I think my top tip with lists actually would be colour. You don't have to print it in colour, but having your patients going home in green just makes you feel so much better, knowing that you know that they're going.
Some healthy OCD.
Definitely.
So, point number 2 was how to have an efficient ward round. So David, Rena and I actually all started off on the same job. We learnt how each other works quite well actually from that. But Rena, what can you add about this then?
Having an efficient ward round, I think makes everything so much easier, and you know exactly where you are. And part of that is getting on well as a team. And I know we were going to talk later about team dynamics and knowing how to get on with people, and that is part of it. But if you've got enough of you, especially on a busy surgical ward round, if you've got one person currently writing the notes at that time, seeing that patient, then the rest of the team can be preparing the notes for the next 2 or 3 patients you're going to see, so that when you get to them, everything's ready. Your senior just has to walk in, see them, and you can just write down the plan. You don't have to go through finding out their OBS and what meds they're on and what day of antibiotics they're on. That makes things so much easier.
Definitely. And I think one of the other things that we used to do is that you should write down the plans on your jobs list as you go along as well. So anything that, any tasks that have to be done from the ward round, write them down on the list. Otherwise you'll end up going back to the patient's individual notes just to find out something you wrote about half an hour ago.
Yeah.
But David, what else can you?
I can only echo what you guys have said. Especially in the sense of having that relay. If there's enough of you, it just makes things so much more slicker and efficient. I don't think there's much more frustrating things for a senior than being by a bedside waiting for you to find the notes, find the blood results, find out what happened yesterday. So if you can get someone to sort of go ahead of the team and prepare everything in advance, and it makes it so much quicker and slicker.
I think another thing that I found as well is if you have quite a few of you, you can also do some of the simple jobs as you go around. So, for example, prescribing some analgesia for a patient or anti-sickness or something, or quickly putting out a blood test that might need to be done later. You can do these as you go around, and it will take you less time to do it on the ward round than it will to write down the job.
Yeah.
So I think that's something else I found as well.
Especially when you've got, like we have in Derby, a computer-based system where you've got the computer with you on the ward round. if you were still working on paper, that might be trickier to do. But I think when you've got computers already at hand, it's good just to get things done.
That was prioritisation of jobs. David, let's start with you on this one.
I think it goes without saying that if you've got someone sick that needs to be seen, then they come at the top of the list. But most of the stuff that we do as F1s on a day-to-day basis on the ward is admittedly admin stuff. I think it differs as to who you are and what way you prioritise things. But in my mind, if there was a job that was potentially delaying someone's discharge, I'd try and tackle that first. Or if there was an investigation that was preventing someone from going for a particular intervention, say for example, someone needed a coagulation investigation before they went for a drain insertion, then you'd do those things first, just to keep the ball rolling with all of your patients.
Rena?
I think a general rule is if there's a job you don't want to do, that your heart sinks at the thought of do that first, get it done. Because
I think we all know those jobs.
Yeah.
Face the music.
Yeah.
And they're the ones that will probably take the most time, and you know that they're going to be difficult, or there's something about them you don't want to do, and get them done, get them sorted, and then you can get on and do all the other stuff that's fairly painless afterwards. That'd be my sort of top tip. But yeah, I mean, sick patients come first. That's always important, like Dave said.
I know that often, especially on medicine, ward rounds often finish about 3-4 o'clock sometimes. So one of my other top tips would be any referrals or conversations that need to be held before 5 o'clock, before normal day teams finish and you need to go to out of hours. Do those well before 5 o'clock.
Yeah.
So that they can be acted on if they need to.
Yeah, I think that's fair.
Yeah. So the next thing we thought of was how to know when to take a break. I think this is something that we all struggled with and becomes really evident actually if you do your hours monitoring. And you realise when you jot down your hours that you actually didn't take a break all day. Rena, what did you find?
Well, this is one of my biggest bugbears, and I'm always saying this to people because I just think it's so important that you have some time for yourself in the day. You need to eat. You need to have a wee. You just need to stretch your legs and get out of the office and away from the computer. We do a lot of admin stuff at a computer, writing TTOs, chasing results. All that is now computer based here. So you need to just get away from that for at least 5 or 10 minutes. And eating is just a massive thing because I see so many people eating their lunch at their desk. And I'm always dragging people off, saying, no, that's enough. That's it, we've got to go and have lunch now.
I think I've been on the other end of that.
Yeah, you have. Yeah. And I think a good time for that is when patients are having protected meal times. And I know that feels a bit odd because sometimes it's like 12 o'clock and you just finished the ward round, you want to get on with stuff. But actually, sometimes it's better. You can't always do much for your patients when they're eating because it's protected. So go then, have half an hour and then come back. Or just once the urgent stuff is done, everybody says, no, that's it, we're going to have a break. Make sure the nurses know that you're going to have some lunch and you will be back and when you'll be back, so that they'll just give you a half an hour break and then when you're back you can tackle things again.
I think some people work through their breaks often because they want to try and get out on time and things, but it actually makes you it slows you down really if you haven't had anything to eat or drink all day. And I think, I myself would say I'm definitely a happier person when I've been fed and watered, so much nicer to work with. But David, what else could you add to this?
I think a lot of people try to think they're infallible and they can sort of plough on through the day with not having a wee, not having anything to eat or drink. But like you said, it relates to productivity. If you're hungry, if you're tired, then you're not going to do that job as efficiently and as quickly as you could have done beforehand. So scheduling breaks into your normal daily routine is a great idea. As a team, saying, right, at 12 o'clock we're going to sit down, we're going to go through the list for 15 minutes to find out what we need to do in the afternoon, and then after that we're going to go for half an hour in the mess and have something to eat and drink.
And one thing that Dave and I did actually when we worked together in our second job was that at 10:30, 11 o'clock every day we took 5 minutes out of the ward round and we had a cup of tea, the whole team.
Oh, that sounds good.
And that was really good because it was a lot of it was junior led ward rounds, which was why that was possible, but actually sometimes there was a natural break in the consultant ward round if they had to go and do something, or sometimes if they were amenable to the idea. You just literally had 5 minutes, had a cup of tea, everybody felt better, everyone felt like they could then renewed vigour. Otherwise, the patients at the second half of the ward round every day
Yeah.
just get a bit of a rough deal when everyone's a bit lethargic and lost their enthusiasm.
Yeah. It's a great way to get to know your colleagues a little bit better as well, isn't it? Because I know
Yeah.
we were lucky in the sense that we started on surgery together, then moved to cardiology, but we didn't know everyone else. So having that 5 or 10 minutes halfway through the morning to sit down over a cup of tea and a biscuit, you know, you can find out things about people that you never knew before. So it's always nice in
Is that a
terms.
good or a bad thing?
I wouldn't like to say,
But-
but in terms of team building, it's definitely worthwhile.
Yeah.
No, that sounds good. And that nicely goes on to our next point of raising concerns and how to sort of deal with your co-workers, whether they're doctors, nurses, or other health professionals. David, what have you found in the last year then?
I think I've been really fortunate in the sense that I haven't really come into conflict or had to raise concerns about anyone or anything, but I'm sure that's the exception rather than the rule. I think people would like you to manage your conflicts locally first. There's nothing worse than having a minor disagreement or altercation with one of your colleagues, whether they be a similar junior or a member of nursing staff, and then just going completely overboard and escalating it. I think we're all professionals, we're all amenable to discussion and talking things through. So if you do disagree with someone about the way they've approached a patient, their management plan, something that they've said to you, then there's absolutely no harm whatsoever in taking that up with them on their own in an appropriate environment. You're not going to sort of chastise them in the middle of ward round for calling you something or other, but you know, there is a time and a place, and you can talk to your colleagues.
There have been a couple of occasions, for example, not so much raising concerns, but more sort of disagreements in patients' management plans or something. And I myself, you know, you go and you talk to the people about it. You find out what, you know, their side of the story, what's actually gone on from their point of view. Because at the end of the day, the only thing that you know is what you see in front of you and what's been documented in notes. But it's always good to get the full story before trying to escalate it to anyone else.
There's often a lot of Chinese whispers as well.
Yeah.
So someone will say that so-and-so said, and it just gets ridiculous, especially I think with relationships between doctors and nurses. If one nurse mentions to one member of the team that another nurse is annoyed at another doctor, I mean, it just gets ridiculous. So actually, if you go and speak directly to that person, you can often clear things up, and there's often not an issue then.
Yeah.
But I think the flip side of that as well is it's really important to feel like you can escalate things if you feel things are being done wrong or there's a dangerous aspect. And I think that if you don't feel comfortable going to a senior, every member of staff can do an IR1 report, and I think it's really important to take away from the fact that an IR1 is that you're getting someone in trouble. It's more about reporting an incident and trying to solve a problem in a system. And if you don't feel like you can go and talk to someone directly, that's a really good thing to be doing, and we should all be doing them more than we do.
Rena, you mentioned IR1, just for the people who don't know what an IR1 is.
Oh, sorry. So
That's right.
so an incident report.
Yeah.
So if something happens on the ward that you feel is dangerous, then it's just an incident report that you fill in. Some people call it datixes as well. To highlight areas so that it can be investigated, so they can find out where they can put safeguards in the system.
And I think
Just
one
about being
key thing about the IR1s is that it's not a blame culture at all. It's more to highlight things that have gone wrong and to try and find ways to improve that and prevent it from happening in future.
Yeah.
Because I know some people are concerned about them just because they think, oh, this person will get in trouble because of it. But it's not for that. Okay, so now should we go on to how to deal with any sort of an emergency? You know, David, Rena and I have all been in several situations where we think, oh my God, I do not know what to do. But I would say first thing I've always thought of doing is just ABC. What would you say, David?
No, completely agree. You know, you get into those situations where you've got no idea what's going on, and because A to E has been drilled into you so much during medical school, you can sort of do it off the cuff without having to think about it, which in turn buys you some thinking time to think, right, what do I actually have to do now? I think medical school is bad in the sense that when they present you with the acutely unwell patient, they always imply that they're peri-arrest. But I don't know about you guys, but a lot of the unwell patients that I've been to seen, yes, they're sick, yes, their observations aren't where you'd like them to be, but you still have time to assess them appropriately and think of a suitable management plan and ask for help if you need it. I think that's the bottom line. As an F1, we can only do so many things, can't we? You know, we can do our A to E, we can rattle off a few investigations, but after that, sort of, we've served our purpose, and there's no shame in asking for help or getting a senior involved. And as long as you've done the things that you can do to the best of your ability, then no one's going to shout at you or be mad at you.
Rena?
Yeah, I completely agree with that statement. And I think once you've got someone past the ABC point, I think the most useful thing you can do is do an ABG. That's the thing I found is just, when I don't know what to do an ABG.
Yeah.
It gives you so much information.
I think it was a consultant of mine actually said to me fairly recently, if you do an ABG, it's because they're incredible tests, but it helps you and buys you some time to figure out what's going on.
And I have had situations where I've had unwell patients who are stable, but I'm worried about. I've done an ABG, looked at it and thought, I am completely out of my depth here. This person is really sick and I am not safe on my own dealing with this. And I've gone via MAU to pick up on-call acute care trainees to say, can you come with me to see this person? Because I'm worried that they're peri-arrest. And, you know, it gives you that bit of extra support when you need it.
Yeah.
I think when I was starting out, and I think it's a similar situation for a lot of people that are just about to embark on F1, is that you're absolutely terrified of one of your patients arresting in some roundabout way. You think that's a reflection of your poor care. And it isn't. If you're called to see a patient and they do look like they're peri-arrest, then realistically, what are you going to do in those few minutes to stop that from happening? If worse comes to the worst and they do arrest, then you just call the crash team and they'll be there to provide your backup instantly. It's not a reflection of your practice whatsoever.
Yeah, and at the end of the day, we're in hospital, and as long as we try to prevent what we can, that's all we can really do. We can't save everyone, unfortunately.
However much we'd like to.
Yeah. So I think this sort of nicely goes on to our next point, which is how to survive on calls. And I know emergencies are sort of the bread and butter of the on calls, aren't they?
Yeah.
But we'll divide this up into sort of surgical nights and medical nights. So from our surgical nights, what would you say they usually consist of?
So there's a lot of fluids, always lots of fluids on nights. There's the odd bit of warfarin that's been left over from the day that didn't quite get prescribed for 6 o'clock. There's lots of things like antibiotics, vanc levels, gentamicin levels that need to be done. And chasing imaging from the day. If there's something urgent that's been hanging over, then that's quite a lot of what you do. Occasionally there's a new obstruction or, you know, a patient who needs an NG tube. That sort of thing comes up occasionally. But I think mainly within Derby there's a lot of new temperatures or patients who are already on treatment on antibiotics having temperatures, needing a review, needing blood cultures. And there's a lot of bread and butter in that. But I think, especially with fluids, there's so much which is nursing staff requesting fluids for patients. And don't be afraid to take a good look at your patient, at their history, and whether they actually need them, because lots of people get prescribed too much fluid. Yeah. And it's just as bad as not enough fluid.
Always check their U's and E's before you prescribe fluids. There's so many patients I've seen that, you know, have high potassiums and yet we're still prescribing Hartmans. Yeah. So definitely check.
And fluid balance charts as well. You know, people say, oh, they're not drinking, but it's actually 2 o'clock in the morning and they shouldn't be having a drink. So that's probably okay, and that might be able to wait till morning for a proper review.
Yeah.
I think if I was ever worried about fluids and you had a member of staff insisting that they needed fluids because they weren't eating or drinking, but like you say, it might be 2 o'clock in the morning, so they wouldn't be anyway, I would always calculate the obligatory volume of urine, even if they're catheterised, because then you can kind of ascertain whether they are producing enough urine, whether their kidneys are sufficiently perfused, and whether they're sufficiently hydrated. So that's something I would always do.
Yeah. But yeah, I think that is majority of what we've seen on surgical nights. That and maybe, you know, a few reviews of patients, if they're post-operative and their site might be leaking or something. Yeah. But then, you know,
and common sense, isn't it? You know, if someone's wound is a little bit leaky, or, you know, they're not feeling very well, then you just have to assess whether you feel they're unwell enough to need a further senior review, or whether you can just keep an eye on them overnight and see what happens. Yeah.
I found that, I know this is more generic to both surgical and medical nights, but I found that my mindset changed. I don't know if it applied to you, but when you're on the ward during the day, you've got your bunch of patients that you're looking after, and your ambition is to try and get them to a position where they're better and suitable to go home. I found that on my nights, your role is changed slightly. It's what can I do to get this patient through till the morning when their day team that know them better than anyone can pick them up and carry on their care. Yeah. So I think that's how it's subtly different to just the normal working day. Yeah,
definitely. I 100% agree with you on that. That you've got an awful lot more of patients. I think, you know, we cover about 14, 15 different wards on a night in Derby. and you can't look after every single one of these patients in the same way that you can during the day. So you do just have to look after people who are sick or urgently need attention, and get them through those 12 hours.
I think that's the key, because I found on my nights in particular, you get landed with a lot of jobs that don't necessarily meet the criteria for having to be seen out of hours. I mean, I can think of an example.
We'll don't worry. We'll go on to talk about that on our next point. But no, sorry to stop you on that. Was there anything else you were going to?
No.
But is there anything in particular you found on medical nights that you'd say differed from surgical nights?
I seem to have a lot of patients with AF on medical nights. I don't know
Yeah.
whether that was just that I attracted them.
I had
but,
SVT quite a few
Really?
times. Yeah.
Yeah, getting confident with management of AF in an acute situation, I think, was a useful thing to know. And generally, my attitude was, as long as I felt competent dealing with the situation, I would manage it up to a point. And I'd always say to the nurses, this is the treatment I've put in place. If you're worried or if things change, just send another referral. It's not a problem.
Yeah.
And then if they'd referred them again, even if I felt the patient was okay and that I'd stabilised them, I would usually just call the registrar with all the information, explain what I'd done, and make sure there was nothing else that they thought I should be doing or that I'd missed. Because especially in the middle of the night, you might not be asking for a review. You may just need some confirmation that you've done everything right. But it can be easy to make mistakes or miss things. And if you've been asked to come back a second time, the person's obviously not improving as much as you need them to. So I think that's always worth bearing in mind, that if you've got a good relationship with your registrar, it's good to just pass things by them.
But on the back of that, I think I agree with you. I found that I called the registrar quite a bit actually on my medical nights, but not so much to come and see the patients, more just to say, okay, look, I've done this, that and the other for this patient. Do you think that there's anything else you want to add to it?
Yeah.
Did you want to come and see them from the story and the history that I've given you? But I think one thing that's important, I remember on one of my nights, one of my regs wasn't actually as approachable as I would have liked. But no matter how approachable or unapproachable they are, if you need a senior review, their personality should not get in the way of that. I know it makes it more difficult at times, but you should still refer to them no matter what.
Yeah.
If you're worried about it.
There's no shame in, I know it's sort of an objective thing, but for feeling needy,
Yeah.
I'd rather, even now going into F2, I'd much rather be seen as someone that's overcautious and always talking to the reg, as opposed to one of these people that thinks they can manage it on their own, only to let their patient deteriorate. That's the sort of thing that will land you in trouble, as opposed to continually pestering the registrar.
Yeah. So I think any more to add on nights?
No.
So one of the other things that I wanted to talk about was the handover of tasks, which I know David wanted to touch on earlier. So when we hand over at the end of the day, so after your sort of normal 8 to 4 or 9 to 5 job, what sort of tasks would you say should be best to hand over to the out of hours team?
Generally, it always needs to be things that are considered urgent, and if you think about it, do they need to be done before the end of that day, or can they wait until the morning? And sometimes people hand over things like chasing bloods, which are not appropriate for handing over to a night team. That's something that you need to do within your day job. If there's a problem there that, in terms of the timeline, cannot be managed by you at that point, then that would be acceptable to hand over. But you shouldn't be handing over routine day jobs like that to an on-call team, because it's just not fair on the person who's covering.
I think one thing to bear in mind is when you do the out of hours, the flip side of it, and when you are that person, you realise how many inappropriate referrals you get, and these actually taper down throughout the year. I think when we first started, there were quite a few that, as an out of hours you were dealing with. Please prescribe this patient's normal warfarin, which could have been done during the day, but the day team didn't get around to doing for whatever reason.
And also, if you're the on-call person, you don't know that patient, so the chances of you making mistakes because you don't know the patient, you don't know their medical history, is higher than the day team who are looking after them all day and know them inside out and can make an informed decision with all that information.
Yeah. And it is when you are that on-call person, it's very busy because you're dealing once again with a much larger number of patients. So to do everybody's routine jobs is just quite excessive, really. So I think definitely try to really think about what you need to hand over to the out of hours teams. David, is there anything else you want to add?
I think you guys have already alluded to it, but if in your mind you think this job can wait until 9 o'clock tomorrow morning when I come back in, then don't send the referral. Whatever you do, don't refer a rectal examination from 9 o'clock in the morning to the night team, because that won't go down too well. But yeah, it's just about using common sense. Like Rena said, urgent things must be seen during the night, and also time-dependent things like vancomycin, gentamicin dosing and things like that, things that can't wait until you arrive back in the morning.
Yeah. So just to kind of finish off, are there any other final tips you could give to our new F1s?
Enjoy it. Try and enjoy it. I think F1 can be an amazing experience. I think it's hard work, and there are days that are really rubbish. But I think as long as you get on with your colleagues and that you work well together as a team, that makes all the difference.
Yeah. David?
I think F1's brilliant because unlike medical school, a lot of the learning that you do in F1 is via osmosis and being there. I mean, my learning curve increased exponentially just by being on the ward, and you don't go home and have that horrible tension headache where you've been looking at books for hours on end. You know, it's very much a be there to see it and learn it kind of thing, which is always reassuring. Like Rena said, enjoy it, don't get bogged down. Be nice to everyone, smile, taking 30 seconds to have a chat with a nurse about how her wedding at the weekend was will do the world of good, and it helps to build that camaraderie that will get you out of some tricky situations if you need it.
And I know I have had days when it's been mad and I've just stood in the bathroom for like 3 minutes and just thought, I just need to get some headspace for a couple of minutes so that I can go out and carry on. And I think everyone I've spoken to has had those moments.
And there's no shame in doing that whatsoever.
No.
Especially in the first few months when you are just trying to get to grips with things.
Yeah.
Crying can be very therapeutic.
David, is this personal experience?
No comment.
So just to summarise just what we've said. So definitely try to keep an up-to-date job list. On ward rounds, definitely try the relay system if you've got enough of you. And if you don't, then maybe have a chat with the senior and see if they could go slightly slower and just clarify plans with them. Make sure you don't miss anything out.
Yeah, don't be afraid to ask.
Yeah.
If you don't think you've heard something or you think you got it wrong, always check, because it's much better to do it then than having to ring them later in clinic.
Try and prioritise your tasks as you go through the day. Definitely take a break, whether it's 5 minutes or whether it's half an hour. Take a break during the day. It will actually help you be more efficient. Raise concerns if you need to, but try and go through sort of the appropriate channels, and then
have conversations first.
Yeah. Have conversations with the actual people that you're concerned about, and deal with emergencies by the simple A to E assessment, and on calls. Majority of it is made up by sort of fairly straightforward, simple prescribing. And then once again the A to E assessments, and hand over only appropriate tasks and enjoy it. I think was nicely summarised there by Rena. But yeah, best of luck. Thank you.
Thank you for listening to another podcast brought to you by School of Surgery. Remember, you can follow us on Facebook at School of Surgery, on iTunes, on Podomatic at schoolofsurgery.podomatic.com, and finally by searching School of Surgery on YouTube. Thank you very much, and see you next time.